Perfect. Thank you so much. All right. So maybe we'll go to the next slide. So I really want to cover a few topics today. One is tell everyone what exactly memory, how memory function. And a lot of common stigma in the society is, or we often heard from our patient is, how do I know I'm normal, right? This could be part of normal aging. How do we know this is dementia? So I think a common I wanted to cover is how do we separate normal aging from dementia? And if so, if there are concerns about dementia, how can we diagnose dementia earlier? And then how can we prevent cognitive decline and dementia development, and what treatment are available there for us? So the very general, a very common concept I tell my patients is that brain is actually just like a library to us. We tend to use it to receive the information. We also need to store them. And then when we needed those information, we actually search for it and then retrieve those information. So it's a very interesting way to think about our brain actually function just like a library as everything else. And then, but there are important functions that involves memory that we often separate them into either short-term memory versus long-term memory. A lot of times our memory or dementia patients or our family may tend to tell us that, I think there's something wrong with my family members. They seem to have trouble mostly in the short-term memory, but their long-term memory is rather intact. So what is the difference between short-term memory and long-term memory? In general, short-term memories, they hold a much smaller amount of information. They actually store much in a shorter period of time. A lot of times much newer. You kind of just received it recently, like someone you met with their names or the telephone numbers people share with you. Those are typical examples of short-term memory. Long-term memory is a little bit more happening or stored in a much longer period of time, and we need a much higher amount of information to be stored. A lot of times we refer to childhood or adulthood experience as our long-term memory. And I think it's important to know that the brain is actually quite complex. There are millions of brain cells in our that works together, right? They talk to each other. They're not isolated. Sometimes I told my patient, we're actually nowadays doing research in the lab. We could get a skin punch of our patient samples and then differentiate them into brain cells. I've grown them in the tissue culture. You actually can see those brain cells talk to each other, surprisingly. So those are the modern technology we actually now can feature or seeing our own brain cells growing in a petri dish. So the cells actually talk to each other. They, during the aging, a lot of times with this kind of communication actually slows down. It takes a much longer time for the cell to talk to each other. So that's when we start to see maybe some kind of processing speed slow down. Sometimes we take a longer time to retrieve the information we need. And so that's part of like normal aging. And there are studies showing that if we continuously learning, right, we could actually promote the new connection between the cells. So that's why it's very important, even when we are aging, we continuously pushing ourselves, learning new things. Those are important components that to slow down cognitive decline. The more neuronal activity or the neurons connection can form between the brain cell to another brain cell, the less the chance of neurodegeneration or dementia could happen in this case. So back to the normal aging versus dementia. We all know that when we get older, there will be probably a decline, gradually decline in our cognitive function. Sometimes maybe you're not as attentive as you used to be. When you're given a lot of tasks to do, you may have trouble to grasp all of that at once. So that could be just normal aging. So how do we know when we call it normal, when we think this might be abnormal? So I think the most important key point is to remember that when there is a benign, we call benign forgetfulness, in general it happens very seldomly and doesn't really interfere your daily function. So it's very important to think about, does it affect me If I go say, okay, I need to work, I need to social with my friend, and I do my daily chores, does this forgetfulness actually come to the way that affects my daily living? So that's important. So when it comes to dementia, or comes to we call cognitive impairment, that is when we start to think this kind of repetitive forgetfulness come to the way, start to interfere our daily living. Let's say we couldn't find where our car parked. We have trouble navigate the neighborhood that we lived in for a very long time. We have trouble finding our keys constantly, or this kind of certain words doesn't come to us all the time, not just once out of blue, right? So those kind of things is talking about frequency, talking about how much it interferes with our daily living. That comes to the separation between normal aging versus dementia. So back to dementia, what exactly is dementia? Dementia is not a disease. It's actually a clinical symptom. It's a collection of different presentation of clinical symptoms. They can be memory problems, can be language difficulties, and can be even behavior changes. Sometimes we may think that why my mom start to think someone's keep trying to stalking her, or taking her money away, or thinking about things that people are talking to her. So some kind of behavior changes can be abnormal, can be the early sign of dementia. And there are many types of diseases can manifest as dementia. One of the most common one is Alzheimer's disease. But certainly there are many other, as you can see in this picture, shows vascular dementia, there are frontotemporal dementia, there are Lewy body dementia. In VA, like for example, we see a lot of veterans, they have exposure to traumatic brain injury or PTSD. They put them in the higher risk of neurodegeneration that is associated with TBI, or traumatic brain injury. That's another set of dementia we often see. So as I mentioned, there are besides memory and cognitive impairment, they could also have behavior and psychiatric symptoms. So let's talk about Alzheimer's, the most common form. So probably you may know there are already studies showing that there are two common changes in the brain that we often see in Alzheimer's disease patients, accumulation of this toxic substance called amyloid plaques and tau tangles. And what happens is that the plaques are this kind of a buildup, as you can see in this yellow buildup in the screen. And the tangles are those intracellular occlusion we often see that from the hypophosphorylated tau. It's another toxin that tends to form in the brain cells. And when they accumulate, they causing the brain cell doesn't talk to each other as well as they used to be. Remember, the brain cell needs to talk to each other and communicate to function like a library to store the information, as we mentioned earlier. But when this kind of toxin build up, they interfere, the brain cell talk to each other, end up to having the brain cell going through death, and that's where we see a lot of shrinkage of the brain. Sometimes when we see patients or families in our clinic, we pull up the MRI, the neuroimaging studies. Sometimes we can show them, we say, take a look. You can see the brain is not as big as it used to be, right? We start to see the shrinkage of the brain. Particular part of the brain that most affected is the one that involves in memory formation, like hippocampi and other part of the brain. So, and as a result, clinically we'll see the cognitive impairment. So there are neuroimaging techniques nowadays we can do to really actively detect those amyloid plaque burden. You can see that in this picture actually shows that if we inject the dye to our patient, now we all can do this kind of study now with our patient, is to have this we call PET scan or CAT scan. Basically, we inject the dye to the patient, and then if they have amyloid buildup excessively in the brain, the toxin we talked about, you can see the brain lights up. Those yellow signals shows up to positive amyloid deposition in the brain compared to the normal aging patient. You don't see a lot of that buildup. So that's the difference. We actually now can actively detect those changes in the brain of those amyloid toxin buildup. And there are studies showing that, if you are age 70s or older, with this kind of buildup in the brain, you have a much higher likelihood to have memory problems compared to those without those amyloid plaque buildup. So there's a very strong data already suggest that there's a clear correlation between this buildup versus their impairment of cognitive function. So between the normal aging and dementia, there is a transition state where we call mild cognitive impairment stage, or sometimes the abbreviation MCI. If you see your family members or patient get to see the doctors, sometimes they will say, walk away with this kind of diagnosis. So what does that mean, this MCI stage? It's actually a transition state where you start to develop some early symptoms. You may still be able to function quite independently. You can still, work well. You can still socialize, but there may be some mild impairment in that degree. Maybe sometimes need to be watched out to checking on your pill sorting, or sometimes need some reminder about your bill paying. But overall, you're still pretty highly functional. You just feel there may be some impairment, like words problems, or some trouble getting, your remember things to do, or where you put stuff in the house. However, it's found that with this kind of mild cognitive impairment stage, it's a high risk for developing Alzheimer's. About 15% of the patients with diagnosis of MCI or mild cognitive impairment end up converted to Alzheimer's disease in the second year of their diagnosis. And about 50% of them eventually converted into Alzheimer's disease. So it is some kind of diagnosis. When you have it, we need to closely monitor it. So then how can we diagnose dementia or mild cognitive impairment earlier? As I talked about, there are neuroimaging approaches we can do, including MRI studies and the PET scan, like for the amyloid burden we talked about, the lighting up in the brain. There's also cognitive testing, which we call paper and pencil test. You actually can come in and do the test, probably about 2-3 hours, kind of testing every part of your memory and cognitive function. Get a very nice overview about which part of your memories got most affected or cognitive function get affected. However, there's also nowadays blood-based biomarker. That's the one major advancement actually recently in the past 2 years that developed in the field, helping us to detect or diagnose mild cognitive impairment or dementia much earlier. Previously, we don't have a blood-based biomarker that allow us to detect or detect dementia more reliably. Now we do. We have a lot more biomarkers available. So I want to go through some of that. I think we already talked about MRI and PET scan, which is the neuroimaging changes we talked about, lights up in the brain. So I'm going to skip this. Neuropsych testing, I talked a little bit already. So they're about 3-4 hours. It can be English. Nowadays in our center, we also develop different languages of neuropsych testing, including sensitive to American Indian cohort or sensitive to Asian populations for us to understand the diverse aging population, their cognitive functions. And then usually involves not just the examination or testing our patient. We also have questions for our family members and the caregivers to get a very nice overview about how the cognitive function of this patient is at this point. And then talk about blood-based biomarker. I want to talk a little bit more about that. Here actually shows a very interesting study that performed or published by Alzheimer's Association this year's annual report, really or testing or surveyed all the patient and family in the sense of if there is a testing available, would they want to know? right? What is the general consensus? Surprisingly, you can see that almost 90 or 95% of patients elect to want to know, even though at preclinical stage, in the sense of they don't have any symptoms, they want to know if they have any risk or the blood test could tell them they could have a higher likelihood of having mild cognitive impairment or dementia. So there are blood-based biomarkers developed so far. As many of you already know, there's one FDA approved just last week. They are particularly detect certain changes, such as the tango p-tau and A-beta changes in the brain. And what they found is that those biomarker changes can reliably, at least up to 90 or about percentage of accuracy to predict how much of that changes in the brain. So without doing the PET scan, like inject the dye, doing the CAT scan, which is quite expensive, sometimes maybe insurance not covering it, now blood-based biomarker allowing us to do this kind of detection in a less costly and more non-invasive way to get that done. And also, so I think it is quite exciting for us because it kind of provide a way for early diagnosis. I think a lot of studies still need to be done to know how clinically, when we follow up, let's say 2 years from now, we do another blood test, the same biomarkers changes, do they correlates with our disease progression at any point, and whether these biomarker changes could really hint, let's say if we put our patient in certain treatment, they really can hint whether the drug is working effectively and slow down the disease progression, or remove what's supposed to be done, the accumulation of the toxin in the brain. I think those studies are still ongoing. We still need to wait those data to be available. But certainly something exciting. We have been talking to our patient. We have a lot of patients nowadays come to the clinic already with biomarker tested done by our primary care clinician before they come to see behavior neurologists. So that's a very nice tool sets we have available nowadays. So a lot of patients may ask me, why do I want to know earlier, right? What does it matter if there's nothing we can do? The truth is that now we can do a lot of things, so it is important to know early, right? So here, let's talk about how, if we know you have a higher likelihood or you have biomarker changes, but yet you don't have any clinical symptoms, can we do anything differently to lower our risk or reduce our likelihood of developing dementia? There are things we can do. So here just to tell you or talk about what can we do without getting into, taking the drug treatment, going to see the doctor, evaluate all that. What can we do just by ourselves, by our own family together? What can we do to slow that down or prevent our cognitive decline? So there are things we may not be able to do, right? We can't stop the aging. I cannot stop, today I'm, 70, next, 10 years later, I'm 80, right? Aging is part we cannot do. Another risk factor is being woman. Actually, women has much higher risk of developing dementia than men, surprisingly. A lot of study going on right now trying to understand why that's the case. But, still, we cannot change women versus men. And then their family history also put us on a higher risk. If you have family members with Alzheimer, push you at least higher risk, double that risk of having dementia. And there's a genetic background in there. There are one major genes that put us in a higher risk of developing Alzheimer's or Lewy body dementia, this ApoE genotyping called ApoE4. I think many of you may heard about that. If you have an ApoE4 gene, and that could create or increase your risk developing dementia by 2 to 10-fold, depending on how many copies you have. So it's a high risk. None of those on the one I talked about, we can do much about it, right? But they are modifiable risk we can. So in the right side, you can see this slide that shows that over our timeline, the whole life, there are early life risks such as education. Then there's midlife risk, if you categorize them like hearing loss, and physical inactivity, or traumatic brain injury, or things like depression, diabetes, smoking, high blood pressure, obesity, all that has a direct correlation with you increase the risk of having dementia. And all this risk can be modified. And then the later time, you can see there are social isolation, there are also visual loss, and there could be air pollution that contribute to the risk of having cognitive decline. And you can see that if we add them all together, almost 45% of this risk are modifiable. Means that if we work on that, we can reduce your risk of having cognitive decline by 45%. So that's doable, right? There are things we can do without taking the drugs, without going through all the expensive evaluation. There are things we can do already to slow down the progression or prevent the cognitive decline. So let's talk a little bit about what are those, maybe break down a little bit more detail. So like I always tell my patient, brain just like your muscle. You have to practice it. You don't use it, you will lose it. So keep practicing your brain function is very important. A lot of cognitive stimulating activities have been shown can slow down the cognitive decline. So what are the things? For example, I listed like crossword puzzles, playing games, and reading, playing instrument. There are patients told me that I love music. I'll put up, classical music for 20 minutes a day. That made it so much different. I like to do dancing, I like to do painting, I like to learn language. Remember, learning new things is very important. That could form new connection between your brain cells, can slow down the neurodegeneration we talked about. So all these are important. Back to talk a little bit about using computer. Right? There are patients ask me how much computer timing is good, how much is not good. So we don't necessarily have a very solid instructional recommendation in general. There are some studies suggesting that when come to online or how much internet time or computer time, lump them all together, it's a U-shaped. What does that mean? U-shaped effect means that when you are using time, let's say average 0.1 to 2 hours a day, usually shows that this tend to be having a beneficial effect in cognitive function. So moderate use of online, like gaming or getting information or learning things, getting new information, those can be helpful, but excessive use turn up to be not beneficial. So that's what that U-shape means. When you become, using too much, I had a patient told me I spend 8 hours a day just online surfing. That's not good, okay? That prevents you to be physically active, right? And that you kind of sitting there doing nothing, that's not help you. And then, so that's passive information receiving. So we really want to have that balanced, okay? While you're getting so-called cognitive stimulating activity, doing the online games or information or learning things, you want to have that balanced out at the same time with physical activity. So then, speaking of physical exercise, it's extremely important to have enough physical exercise building your daily routine. And that has been shown significantly improve the memory, enhance our patient's attention, and also can accelerate the processing speed. And there's also a study showing that after very routine daily exercise, the brain volume increase, we can prevent the atrophy, the shrinkage of the brain. There's many more studies also shown that it's not just put a lot of emphasis on the brain health with exercise. It can also improve your heart, your lung functions that subsequently can improve the perfusion of the brain, means like the blood supply to the brain. So that's very important. And also help to improve the metabolisms of our brain, and then enhance that brain-brain cell and cell interaction and communication. So all that is important. And it also can reduce the risk of stroke. Remember, cardiovascular risk like diabetes, high blood pressure, stroke are all high risk for having cognitive decline. So overall, really physical exercise is very important. Then question is, how much would be suggested, right? A lot of times my patient like to say, give me a specific time, how much exercise I need to do. The easiest way I would recommend is that probably come to about 2 hours per week kind of exercise, mild to moderate exercise. So certainly safety is important. I always tell my patients, safety is a top priority. Make sure you are safe. Someone walk with you. If you are not, falling around, you have someone always, watching you. If you have some balance issues, if you are capable of doing at least 2 hours per week, break them down into either 20 minutes a day, 6 days a week, or you can do maybe bulk exercise if you want. As long as you hit that 2 hours per week, that's pretty good, okay? So try to build a good daily routine, including physical exercise, cognitive exercise, and then let's talk about other modification we can do. There are, as I talked about earlier, the vascular factor plays a big role in accelerating or increase our risk of cognitive decline. What are they? High blood pressure, diabetes, cholesterol, smoking, obesity, depression, all that play. So if you have a not well-controlled high blood pressure, not well-controlled diabetes, make sure you work with your primary care, get those addressed. Okay, those are important. And then let's talk about diet. What's the good, food? What you put in your mouth, what you're eating affects yourself too. So there are a lot of data have already shown that Mediterranean diet has been very well studied to slow down or prevent cognitive decline. Here just list you some of those good food that we want you to try or building into a daily recipe, and then the bad food you want to stay away from. Okay, fried food, processed food, red meat, those are things you want to avoid. More berries, more green food, those are good to build into your regimen. And another thing I want to talk about is supplement. A lot of my patients come to me, bring bottles of supplements over the counter, nutrition or vitamins, ask me, is it good for me? So the answer is there's no solid data support any over-the-counter supplement would be beneficial to slow down the cognitive decline. So I tend to tell my patients, don't waste your money on those supplements. They can be quite expensive. Most common one, Provigen. A lot of my patients come to me would bring that. Ask me, is that helpful? There's no clear data for that. So I would recommend not to waste your money on supplements, okay? Then cognitive stimulating skills. There are things we can practice. Our brain can be, practiced. A lot of skills we can do. If they say, I tend to forget where I put my key, where my wallet, where my phone is, make a specific location for those things. So you know where to find them if you can't. And you always put them back. Try to remind your family members, put them back, and make a to-do list. Always remember, I always tell my patient, have a big whiteboard, come up in the kitchen or anywhere, write down what to do today. From morning, every single steps to the time, dinner time, make that clear to them. Sometimes they may still forget. They will ask you. Then you'll say, let's go take a look at that calendar and see what we do. What time is it now? What can we do? So make a to-do list. Keep the timer, keep the reminder. Always help to remind. And then certainly pillbox, you probably all know how to sort out that. And there's a lot of things also can be mindful about when it comes to stimulating strategies. A lot of times our elderlies tend to find it's very hard to do when there's multitasking. So try to do one task at a time. Don't overwhelm yourself. Focus on, just one at a time. Slow down, take your time, okay? And always, when you do that one task, try to focus and then repeat what you learn. Reinforce is very important. Writing down things, making things into categories, make meaningful connections between things. That helps you to memorize better. We made a lot of acronyms for all this lifestyle modifiable ways to improve our cognitive function or slow down the cognitive decline. Very common one we talked about recently is called a SHIELD, right? Abbreviates that covers really sleep, stress, interaction with friends, exercise, learning, diet, right? Together, SHIELD. We also have another acronym is ABCD, really just to talk about, A stands for exercise, all the activities, right, that you could do. And then B is engaging your brain with new skills. C is like connection. And then D is like diet. So really just a way to help everyone to remember what are the good things you can do to be helpful with your brain. So regardless the acronym, it's really just to think about, maybe every day think about, do I do something good for my brain today? Am I eating a healthy diet today? Did I do my exercise today? Am I doing some exercise with my brain, with the cognitive games or any kind of readings I like to do, listen music I do? So those are the things you can do a checklist in your mind and see what that can help you. So with all that, then I want to talk about medication. So there are newer medications nowadays available. Here just to list you some of the ones that being in the field for years to treat Alzheimer's. Sometimes we even use that for other type of dementia as well. There are symptomatic treatment, really doesn't change the disease trajectory, doesn't offer any slowing. Those are probably some of them you heard about, like the lampazole, rivastigmine, and memantine. Those are the drugs that we commonly prescribe in the clinic to our patient. There may be one study I do want to point out is that performed maybe a couple of years ago, really a study done by Swedish group. What they did is that they actually did a 5-year longitudinal study, and they found that those are on this, either Aricept or rivastigmine for up to 5 years. There may be a tiny bit of slowing in their disease progression, like about 5%. But even though they are modest, very little, but still significant. So in general, in my patient, if they don't have any side effect respond to those medications, I still try to keep them on if they can tolerate, because of the study showing there are some modest improvement or beneficial effect in that case. So then there are newer drugs now. So there are drugs we recently approved. There's one approved in 2023, lecanemab or Leqembi. And then there's one approved last year is donanemab or Kisunla. So these are new drugs that are now available we can offer to our patient. That's very new. And what those drugs do? These are we call disease-modifying therapy. So that particular means that it actually changed the disease trajectory. It actually can slow down the progression of Alzheimer's disease. Remember we talked about those yellow, build up the toxin we can detect in the brain, those amyloid plaques. So these drugs are targeting those amyloid plaques, try to remove them, clear them out into the brain, and then can slow down. There are data showing that if we start early, again, back to early diagnosis is important. Why that matters? Because when we start early, we actually can see a lot of more beneficial effect. We can slow this down. So if we treat the drug up to 18 months, we actually can see the slowdown by 20 to 30%. A lot of times patients ask me, what does that mean? That means that we can stabilize the disease by additional 9 to 10 months. That's a big difference, right? So what does that mean? It means like they can still maintain where they are, where their function status where they have. Let's say if we are still able to stay at home, we still do all the things we are liking to do, we're still relatively independent, we want to maintain that independence as long as we can be. So we try to do that, at least with these two drugs now available, we can at least extend that time where they remain more independent stage longer. They are not cured, unfortunately, right? We not yet have a cure for Alzheimer's disease or other type of dementia. We're still exploring, we're still working very hard to find a cure. They're not cured yet. right? But that's something at least we can offer nowadays. As you can see on the right side panel, there are studies also done by Alzheimer's Association, really asking an opinion about patient and caregivers about whether they are interested to get the medication that can slow down the progression. Even though we're not perfect, we're not getting a cure yet, are they interested in that? As you can see that almost 90% or more are really showing that they really want to, either probably or definitely yes, to those medications that can slow down the progression. So I think when we talk about medications, while we are not yet come to the cure, there are many things ongoing in the field. As you can see, this is a very busy slide. That's the pie chart, really show what's going on in the field, working very hard to develop new drugs, better drugs, that could potentially cure Alzheimer's disease or related dementia at one point. So you can see some of them are in phase 3, means that we're very close. If we get very good positive result, they could end up in the clinical practice that we can offer to our patient. Some a little bit far from that, phase 1, phase 2 trial, still need larger study to prove they are actually indeed helpful, but there are many studies ongoing right now in the field in different parts. So I think it's important, I want to get a message to our families, our patients as well, is that it is important to be part of this clinical trial or clinical studies because that could help us, for one, to know our own risk and resilient factors. What makes us different from others? What makes each one of us, either more susceptible to dementia or more resilient to dementia? And what is our genetic risk? What is our, other non-genetical, but based on all the medical conditions, all the environmental exposures, or other components that made us more prone to have dementia. And then, there is also annually we'll follow up with the study, kind of do the evaluation to see where you are today versus a year from now versus 2 years from now. Really, are you stabilized or are you in the right trajectory, in the aging trajectory, or you decline way faster than you should be, and that has a higher likelihood maybe you are starting to develop early dementia. And then also we have this resources that we could share all the information from the clinical trials and all the available studies that you could be part of that, and you also get information with support to your families and loved ones. So here, just to briefly talk about our setup in the Grossman Center, we do have our patient care. That patient come to our memory clinic, get evaluated, and then either to see they are eligible for the new studies or new drug treatment, or they are able to get into the standard care. And now we also have our translation and clinical research arm where we actually recruit patients for what we call the clinical research. We have a brain health and aging registry study ongoing right now, open to all the community as well as our patients and families. If you are interested, you can sign up for that research study. It offers a lot of evaluation from blood-based biomarker to genetic risk evaluation to the skin punch we talk about that can differentiate your own cells into brain cells and study whether your cell responsive to specific drug treatment that we are testing in the clinical trial stage, or go to the annual neuropsych testing, the evaluation of your memory baseline over the years, follow up on that, and then to all the recruitment into clinical trial that we are running. So this is just a brief summary of what we do. As I mentioned already, it's a multidisciplinary involvement, not just neurologists. We also have neuropsychologists, our social worker, our care coordinator, and our research team all together really work to get the diagnosis to you, even though it's a research diagnosis, but can be used for clinical practice. Some of our patients have that information available, bring to their primary care or neurologist to share, let them know where they stand with their neuropsych evaluation and their biomarker changes or their genetic risk. We do annual follow-up and recommendations, and then we follow up over the years. So these are the contact information. If you're interested, feel free to reach out to us and sign up for that. Thank you very much.
Thank you. Thank you, Dr. Cai. I would like to open it up for some Q&A now. So everyone attending here in person, there are some note cards on your table. So if you have any questions for Dr. Cai, please write those down, hold them up in the air, and we'll come around and grab those. So we'll start with a question online, and then we'll jump into our in-person questions.
All right, so this first question is about assessing short-term memory. How do you differentiate between failure to retain and lack of attention?
Say that again, sorry.
How do you differentiate between failure to retain information and lack of attention?
Right. That's a good question. So there are several batteries of tests in neuropsych testing, as I talked about the paper and pencil testing, that can separate the processing speed versus the memory retrieval. So we have several batteries of tests that we do to test, including language, executive function, visual spatial, as well as memory. So each of the domains of those neuropsych testing will tell us, whether the patient is slow in processing speed or slow in memory retrieval. So there are many ways we can do that.
Dr. Cai, we have one question from the audience here. Let's start with a support group related one. Do you have a support group for caregivers that are working with clients with MCI, mild cognitive impairment?
Yeah, very good question. We're starting to develop our caregiver support group. Certainly, we team up with Joe's team, as you can see, together. I think there are many things we can do right now. Another major component we are building right now is the outreach and education part. We are starting to we're going to start our annual symposium for caregivers, particularly targeted to either MCI or different dementia groups into that. That'll be our next one. I think the information to be followed, we're hoping to organizing one event in that regard in fall of this year. I'll keep you guys posted.
Thank you. Ashley, do you have any more there?
I can do another one from online here. You mentioned a little bit about the over-the-counter products and it potentially not being worth it to purchase. Is there reliable data that green tea decreases the development of dementia?
Answer is no. There's no reliable data to support that. If there are some ongoing study in, probably vitamin supplements or other particulars dietary supplements that currently on the clinical trial. But as far as I know, there's no robust data that really support the over-the-counter supplement. So that's why overall, so far, my recommendation is still, there's no clear evidence suggests that. I recommend against using the supplement in our patient.
The next question here from one of our in-person members asked about the age that someone might have a biomarker test, particularly if someone in their family has early onset Alzheimer's. Is there a recommended age? They do mention specifically a 45-year-old adult.
Right, yeah. So I think when it comes to age, there may not be a specific cutoff or suggested criteria for just a concern per se. If patient already have some we call subjective cognitive complaints, then usually I would recommend they see primary care physician and get a blood-based biomarker tested if the concern is high. For the family members, on the other hand, which has no cognitive complaints whatsoever, subjectively doing well, just because have increased risk of concerns because of the family members, my recommendation is that probably they can sign up for our research. They want to get biomarker study through research. That might be a good way to get that. And usually our research open for 45 plus, yeah.
On here? Okay. Dr. Cai, do meds slow progression of mild cognitive impairment if it hasn't become Alzheimer's yet?
Do what?
Medications.
Oh, medication slow down
the advance of MCI if it hasn't become Alzheimer's
Oh,
disease.
I see. Is there medication that slow down MCI before they become AD? Yes, Alzheimer's. Correct. So yeah, there are medications. The two medications we talked about, lecanemab or donanemab, are indicated to use in mild cognitive impairment patient stage. Actually, even work better at MCI stage than the early dementia. So we have quite a few patients currently getting infusion now at Fairview, the infusion center through our St. Louis Park Memory Clinic, getting the infusion at mild cognitive impairment stage. But they need to be confirmed, we say biomarker confirmed Alzheimer's disease, in that sense that MCI is a very broad term. You can be mild cognitive impairment for many reasons. Even depression can make us to get diagnosis mild cognitive impairment, or it could be vascular dementia causing, vascular components causing you have mild cognitive impairment. So it's a rather broad term. But the medication we talked about, the lecanemab, the donanemab, only indicate if you are mild cognitive impairment because of Alzheimer's. That requires biomarker confirmation. We will need you to get a PET scan to show, or spinal tap to confirm there are accumulation of those toxins in the brain that these drugs are targeted on, allowing you to be eligible and get benefit from those drug treatment. But simple question, yes, there are medication for MCI. Yeah.
And continuing to talk about some of those newer medications, could you tell us a little bit about the frequency of side effects, or if there's any indicator as to who might have some of those negative side effects compared to someone who might not?
Right. So yeah, that's a very good question. So the two medications that we talked about, the lecanemab and donanemab, they are infusion medication, and there are side effects involved or associated with using this type of medications. And some side effect could be serious in a way that we call ARIA, or in general terms, I told patients it's just that could be severe to a degree that causing brain swelling or brain bleeding. So there are certain risks or certain things that we know now that increase that likelihood of those side effects. And we work very carefully to screen those potential risks to avoid those side effects. One would be, if you ever had a bleed already to start with, that puts you on a high risk of developing bleed while you're taking those medication. Two is that if you're taking blood thinner, right, like Aliquots or Coumadin for other reason, that you have a higher likelihood of side effect. So for those patients that are on blood thinners, we don't typically give them those medications. Another risk factor we talked about is the ApoE4 gene. So there are studies showing that if you carry ApoE4 genes, you have a higher likelihood of those side effects, particularly for those that carry 2 copies. Remember, we all get 1 copy from the mom, 1 copy from the dad. Sometimes, unfortunately, both copies end up to be the bad gene, ApoE4. And in those patients, the likelihood of side effect, the swelling and bleeding, are very high. So far at our practice, we're not offering ApoE4 homozygous or the 2-copy ApoE4 patient with those infusion medication because of the concern of the risk of bleeding or swelling.
All right, I've got another question from online back here. So for patients that might be diagnosed with memory loss or Alzheimer's disease, they're wondering about implications for medical insurance and issues. Do insurance carriers tend to drop coverage if they know that a person might be diagnosed with Alzheimer's? And I'll add in addition to that, if you could speak to medical insurance and like insurance for driving, that would be great.
Right, so insurance, as far as I know, I don't believe because of your diagnosis of dementia, the insurance would drop you. I'm not aware of that. If so, let me know. That's the case. We'll try to figure it out for you. And then two is that all the drugs we talked about, the new drugs are currently covered at least by Medicare. So a lot of our patients have Medicare, they are covered through this. They are expensive drugs, out of pocket can be quite expensive, but we work with our patient and family. We were able to navigate through the insurance policy and get most of our patients covered through insurance. For the newer drugs and biomarker too. Nowadays, we're trying to push for the coverage of biomarker study, the blood-based biomarker as well.
I have so many good questions. I wish I could ask them all.
I'm here.
This one is about testing, quick testing that can be done in a clinical setting. What is your opinion about using quick screening measures like slums, mini-cog? When are they useful, appropriate? Who does them, or when are they not useful?
Right. I think mini-cog is good for screening at the primary care settings, and I would recommend annual visit, wellness visit for our aging patient should be done. Slum or MoCA or mini-mental would be nice to be probably performed at behavior neurology visit as a better screening tool. They tend to be more effective at early to, mild cognitive impairment or mild dementia, moderate dementia, slightly lower value when come to that stage. More advanced stage dementia, those tool sets tend to be less effective or helpful.
Sure. So another question here. We're wondering how common is depression-induced dementia? Is it reversible, and what is the most effective treatment?
Good question. So depression can be a contributing factor to dementia or cognitive decline, and sometimes dementia can be a type of or part of the symptoms we see with dementia progression. Sometimes, or even early sign. A lot of times our patient may be withdrawal. They don't want to talk to others because they don't feel confident with their communication skills, or they don't feel comfortable to be there, interact with others. So there are things very critical to recognize those signs and symptoms and getting treated for. There are medications can be very helpful in controlling depressive symptoms in our aging patient and dementia patient. And talk to your specialist, have also psychiatrists or psychologists on board. Psychotherapy has been found also very helpful. Not everything need to be taking a drug to do that. Psychotherapy can be also very helpful.
All right, we will have time for one more question here. One from online. Can you talk about hearing loss causing dementia, or what studies support that?
There are actually very recent studies showing that hearing loss at least contribute about 7% of cognitive decline. Exact mechanism probably not so specifically spelled out, but I often tell my patient that you live in an environment, you need to receive information, you need to interact. When you have trouble hearing, you're actually not as receptive or attentive to your environment. That kind of, in a way, considered as a social isolation. So that probably contributes to some of that cognitive decline. So a lot of my patients, I ask them to do hearing screening every year, make sure their hearing is being tested. If they are detecting hearing loss, I always encourage them to get hearing aids and make sure you get a good one, high quality one that really works. A lot of our elderlies tend to complain the hearing aids doesn't work well, they don't fit well, so getting a very good one, high quality one that really works is important.
Thank you so much. That does wrap up this first session. Thank you, Dr. Cai.